Good morning. I'm Deanna Larson. I'm the Chief Executive Officer of Avera eCare. And my goal here today is to talk to you about the work that we've been doing in virtual health and telemedicine now in 21 and what we've done over the historical period of time and how we see that moving forward. Next slide. So I represent Avera eCare, and you see over on the right side there of the map, you see the origins of Avera eCare residing in the middle of the United States in South Dakota, North Dakota. These are very rural states in that we have a very small density of population across those states. And we've been doing the work in telemedicine for about 10 years. And you can see that our goals there were really to make sure we could support delivery of excellence and support collaborative care through the vision of providing telemedicine across all these spots. And then really important to us is that we could see that we could augment care locally in all of those small communities. So starting out where the circle was, and now all of the states that are grayed in represent a location of a telemedicine service that is represented by Avera eCare. So over 600 sites in 32 states, we impact millions of lives, both those of the healthcare professionals as well as the patients that we take care of together in collaboration with each of those providers. It's interesting to know that in the United States, there is a lot of less dense populated areas outside the metropolitan areas, and we serve upwards of 20% of all of the what we call critical access hospitals, small community hospitals that provide care and services in those states. So we have really been able to take on a model of care that is supportive to the physicians and nurses and pharmacists and also impacts good outcomes of care. Next slide. These are the scope of services that we provide across all of those areas. So you notice on the left side, we have a clinical service offering that supports care in ICUs. We support care in pharmacy, in emergency centers, and also hospital medicine or hospitalists and inpatient behavioral health. Those are all on-demand services, which means I have a hub of physicians and nurses and pharmacists and those support individuals who provide 24/7 access to those 600 communities, calling us when they need us to support. Maybe in the emergency setting is always a good example. Several of our small community hospitals have really had a struggle, if you will, to provide 24/7 care due to the difficulty of retaining and recruiting physicians, nurse practitioners, pharmacists, et cetera. So what's been really important to us is that we have our physicians and nurses licensed across all of those states, and then they are appointed in these hospitals. So they are a partner, and they actually work on the medical staff of those hospitals. So it's an augmentation and a collaborative care model in emergency. What this offered is at night, often at night, there will be a nurse practitioner or family physician working in the emergency department. And then if there's maybe a trauma case, a heart attack, or a neurostroke, they can hit a button basically and get connected to boarded ED physician as well as critical care nurses who bring in those extra hands, workforce multiplication, bring in those extra hands to do the calling, maybe for transfer. They actually assist them with intubation using video camera, laryngoscopy. And it's just, just such an important aspect of collaborative care that's going on at the small community hospitals. And the reason you want to think about this, our goal was to really make sure that patients who show up at a less metropolitan hospital, more rural in nature, that they have access to the same level of care. So our outcomes in intubation, as an example, early clot busting and stroke or heart attack, our times are the same as those that were occurring in the tertiary facilities. So again, early access, giving the local community hospital the collaborative providers to work beside them, just like they would if they were in a large urban hospital. And that's been very successful for us. It's been very successful for saving lives for patients. The same situation would be in ICU. We have critical care intensivists, we have pharmacists here, we have hospital medicine, and of course, psychiatry. The next one talks about post-acute care. So what do we do there in our post-acute care setting? These are still on demand. This is 24/7 support for seniors living in skilled care nursing facilities. We have some going on today in the home setting where we're supporting family members and individuals providing care for themselves, giving them access either to video and or phone and that support. And this middle piece was very important to us during COVID, and I'll talk about that in just a minute. On the last slide, this is on demand, but it is just really Monday through Friday. So you want to think about, we are available all the school days for school health to have access to a school nurse. This is very helpful in those children with juvenile diabetes, asthma, et cetera, as well as those bumps and bruises, or just some help with those students who maybe have extra needs that the teachers really enjoy having a nurse available to them. A scheduled specialty clinic includes all of the specialists that can maybe see the patient as a consult from the family practice provider or the primary care provider to really take them maybe to cardiology, pulmonology, et cetera. That one is a scheduled visit. Again, we call the patient and that's scheduled. Avera now is direct to consumer access. Anyone can call in. And then we also really do have that consult piece across all organizations where we can do a physician-to-physician consult. So that's a very large overview. We've built all of this telemedicine over the last 10 to 12 years. It's been an incredible journey. We really believe we are the augmentation of healthcare. We're the access, but a lot of what we're doing, the most important part of all this network of technology is the workforce. We are workforce acceleration of the workforce. We extend the workforce. We are able to help local communities recruit because they know they'll have this set of colleagues. And we've also had the opportunity to extend clinicians locally because they know they have this kind of support. Next slide. And so in addition to those things, we've just put a few things on this slide that will help you understand the impact that we've really understood and been able to live over the last 10 years. So it does really impact the lives of patients. Patients like to stay local whenever they can. And so having patients living in a small community receiving care there is very good for the economics of the community if they can receive care there and not travel into the urban center. Cost of care, because we're there very early on, we often can help reduce the cost of extended illness, spiraling up of an illness that needs an early intervention. We can be there and assist that in occurring quickly. We, as I mentioned earlier, for physicians, nurses, all the way up and down, pharmacists, et cetera, we've been able to stabilize that workforce and really helping them engage to stay locally, getting them better volumes of patients to stay local. And they're really satisfied with that care as they're able to provide more care locally. That's what they really wanted to do when they went off to be educated in the role that they have. And so this has been very satisfying. And patients love it. Of course, we found that out during COVID, that the patient satisfaction is high. We knew that before COVID. But since COVID, we know that there's also a high demand. Patients are asking their providers, can I be seen at home? Can you do part of my follow-up visits at home? And I want to be able to reach you on video. So these four impacts have been very real for us, and I think even more noticed during COVID. On the right-hand side, I wanted to bring a couple of those out for you too. So knowing that the physicians in those communities even indicate as they're trying to do recruitment, retention, they're indicating through survey that it's really impacted their ability to recruit and retain clinicians there longer. We do know that operating margin of those, especially small community hospitals, is very low. And so what we know is we can increase their operating margin by retaining more patients in that community through the help of especially that inpatient side in the ICU, the ED, and then the hospital medicine. It's been very important for them to increase their retention of patients versus transferring them into the tertiary facility. Timelier access to our hub physicians as especially in the ED, increases time of access to a physician by 21 minutes, because in many of these communities, the physician may be at home or at the clinic setting, providing care there. And so they have to leave that situation and come in, again, an average time of 21 minutes. And as you all know, clot busting and life-threatening situations, 21 minutes is a very long time. Our adverse drug events, we're actually able to support as they review all of those orders written and interact with the ordering prescriber on changing of medications to make them more safe. We've really had a huge impact as well. 88% of all of deaths are related to drug interactions or poorly prescribed medications. And so this has been a huge uplift as well. 90% decrease in times the local providers had to come into the hospital. Of course, you can imagine overnight, you get some things into the ED, into the hospital where the local provider has to get out of bed. They're the only one available versus having someone to call in their stead overnight. Of course, they're available to come in if the need is there, but if we can provide that care and service via video, then they can stay in bed and sleep and be fresh for the next morning, their hours of care provision the next day. So this has been a huge opportunity as well. Students staying and remaining in school, always a big deal, versus sending them home to parents, maybe unnecessarily, parents having to leave work. 90% of the students we see stay in the school setting, as well as when we have the lives saved with our EICU has been incredible. And we're there very early to support the intervention. And the unplanned transfers of residents out of skilled nursing facilities, 62% improvement. That's a reduction in high cost of care and unnecessary care that often happens as they enter into the hospital setting. And often we know that elders can leave a hospital setting not very confused and at risk for falling and injury, as well as picking up nosocomial infections while they're in the hospital. So reducing those transfers to the hospital has been a very big and important issue for us. Next slide. So what happened during COVID? I see always, I always have to say, I don't know if we had rapid adoption of telemedicine. I'll say there wasn't another option. Our hospitals and clinics were all closed down. There just wasn't really the ability for physicians who worked in the clinics and even, in the ORs, et cetera. Those things were closed to the patients that they wanted to provide care for. So there was a really quick utilization of telemedicine, and the federal government made it very open and available to them to use many platforms to get on video with their patients, and their patients, of course, needed some help. Many of our chronically ill patients needed access to their physicians, and the physicians were scrambling and wanting to be there for them. So during that time, there really was, it's one of those situations, what do you do when there's a crisis? And it was a crisis. And so we had huge uptake of telemedicine, and it really showed a lot of support both to the patients as well as the support that was provided to the physicians. Now also being able to stay at home, they had less risk. Maybe a pulmonologist could make some of their rounds on a COVID positive patient in the hospital without having to go in, completely use all the protective equipment to go into the room. Instead of that, they could use a video, go in and out and do some testing and talking with the patient. So that really reduced some of the use of the PPE, as well as reduced the risk of our physicians and nursing staff being unnecessarily exposed. So in both situations, there was just a huge uptake in the acute care setting and also physicians calling patients at home. So, the remaining task with COVID was now, since our eyes were opened across the nation, we really understood the potential impact. There's some regulations and some payment issues. There's some licensing issues that need to continue to be addressed and understood deeper. But I think there's no doubt that the appetite for telemedicine has been strongly encouraged, even by those who thought that they wouldn't like telemedicine. This COVID experience opened that door wide up, and you saw clinicians engaging with technology to provide care and services to the patients wherever they were. It was a beautiful experience, and I do think that there's so much more to come out of it. It's been very exciting, something we've been prophesizing for some time here at Avera eCare, so we're very happy that it went the way it did. Thank you for your time today.